Okay, good afternoon, everyone. I think it's just turned 1 o'clock, so we will get started. My name is Tom Campion. I'm one of the BSNR Training and Education Subcommittee, and I have the pleasure of introducing Dr. Tilak Das today. So Dr. Das is one of our RCR BSNR Du Boulay Professors, and you met the other Du Boulay Professor last week, Dr. Mills. And today he's going to be talking to us about meningeal tumours and mimics. We've got lots of Paxman cases for you today. I'm going to put the link to the first set of cases in the chat now, so please do open those up and get them loaded. And now I'm going to hand over to Dr. Das, and the screen is all yours.
Great, thank you very much, Tom. Welcome everyone. And yes, today's brief is to talk about, in our last lecture on neuro-oncology from the BSNR series, we're going to talk about meningeal tumors and their mimics. So we'll start with a very brief anatomy, and then talk about one of the sort of key questions that we come up with in radiology, which is, is a tumor intraaxial or extraaxial? And then if it is extraaxial, then what is it? Of course, most of the time it's going to be a meningioma, so we'll spend some time talking about that, and then look at other dural tumors, but also a little bit about leptomeningeal diseases. So we're all very familiar with dural or meningeal anatomy. We've seen diagrams like this over and over again, probably, but it's a good reminder that the brain is essentially suspended in CSF by these membranes. So you have the skull with dura adherent to the skull, the dura mater, the tough mother, and then the arachnoid mater, the spider-like one that's attached to the dura. With CSF between the trabeculae and the subarachnoid space, and then those attached to the pia, which itself is attached to the surface of the brain. So the brain is suspended by these layers. And histologically, it has quite a unique appearance. So this slide from a book is of normal dura. You can see it's fairly sort of bland-looking tissue, but very characteristic. So it means that pathologists can easily, reliably identify this tissue in specimens and know that they've got a specimen that includes the surface of the brain. And this slide shows images of the arachnoid membrane, much thinner, and you can see the spaces extending down to the surface of the brain, and this is the pia here. Okay, so on imaging, what can we see in terms of the meninges? So this is a sort of 2D flare sequence, and you can see that even without contrast, you can just about see the meninges overlying, or the dura at least, overlying the cortex. Much more difficult to see on T2, and that's likely because it is hypo-intense on T2, like the falx here, but applied to the skull, to the bone. And then on 3D sequences, which are used more commonly now, both unenhanced and post-contrast, you can see the dura quite well, such as in this example. This is with contrast, and there's a difference between how visible it is with field strength, but also the type of sequence. So dura tends to be more readily seen on gradient echo sequences compared to spin echo, and better at 3T than 1.5T. In the past, the description of normal meninges on MR used to be of a sort of broken line of enhancement, not always continuous, but you'll notice now on these 3D sequences, it's much easier to see it as a continuous line. And the sort of extra enhancement along the dura is likely related to vessels. But if dura is abnormal, then it tends to be seen as much thicker uniform or enhancement of some sort. And you can see on the flare without contrast that the dura is quite readily seen, and with contrast, very easy to notice. Okay, so the first question, of course, is going to be, is a lesion that you've seen intraaxial or extraaxial when we're considering the meninges? And so here's a classic meningioma with very typical appearances. On flare, on the sagittal flare, you've got a hyper-intense mass with underlying edema in the parenchyma. It's sort of fairly homogeneous, T2 hyperintense again, and you can see a very clear cleft of CSF. So this is your CSF cleft sign, and the parenchyma around it has buckled, so it's collapsed or indented, and which is usually fairly clearly seen as well. With contrast, there's homogeneous avid enhancement, and there's also a little bit of thickening of the dura that the lesion has originated from. And so those are some of the signs that are typically used to identify an extraaxial lesion. And of course, intraaxial lesion, in this case, a diffuse glioma. We saw a few of these in couple of weeks ago, and much more obvious that it's within the brain parenchyma. It's not even near the surface there, but medially it herniates under the falx, and there's a poorly defined border with the rest of the brain parenchyma, and no buckling of the cortex, as we saw, unlike what we saw before. So that brings us on to our first game, and this one actually even has a theme tune. Well, sort of thought of it yesterday, and maybe before every MDT I'm going to do this, and it goes something like in, out, you've got to work it out. Do a scan with GAD and scroll around. That's what it's all about. So we're going to play the intracranial hokey cokey. And what I'd like you to do is to load up the first collection of cases. So you've got 6 cases on Paxman, cases 1 through 6, and have a look through all of them. They're just limited sequences, T2 and post-contrast T1 or flare and T1. And we'll open up the first poll, which is simply asking you to decide whether each lesion, each case, is intraaxial or extraaxial. So if I give you the 6 cases, maybe about 30 seconds each, plus a few seconds for loading time, etc. So we'll join you back in about 4 minutes. Thank you very much. Just a note of caution, the questions obviously labeled 1 through 6. The cases aren't exactly in that order on Paxman, so the bottom case is number 6, but the top case is 5, so just be aware. Okay, so Tom, I've failed in my first task, which is to actually set a timer. And so let me know if I'm overrunning the time. Okay, we'll just do another minute. There's quite a lot more votes that could come in. So just a reminder that the question has all 6 cases, answers for all 6 cases in one question. But you should be able to close your poll window and reopen it if it's in the way. Okay, let's close the poll there, I think, Tom. Thanks. And have a look. Great, okay, so quite a few answers coming in. So interestingly, there's a few where there's a clear majority. Case 2, 3, and about 2/3 for 4, 5, and 6 majority. And so those are a bit more equal, 1, 4, 5, and 6. So 2 and 3 were pretty obvious to everyone, well, to people, and 1, 4, 5, and 6 not so much. Okay, so what we'll do is I'll just have a look. We'll have a look at it on the summary slide here. So yes, case 1, enhancing mass, very close to the surface, of course, and there's a bit of dural thickening or maybe dural reaction just under that. There's a very thin hypointense line between the dura and the lesion, and but certainly not obvious. And this was actually an intraaxial mass. This is a lymphoma, as it turns out. Pretty unusual. Case 2, much more classic. So huge, lots of cysts, multicystic, but there's clearly a collapse of the parenchyma here, and it's folded across with possibly a small cleft sign. So that's a bit more clearly extraaxial. Case 3 is an interesting one. So I call this extraaxial when I first saw it. And surprisingly, it came back as a metastatic squamous cell cancer. And apparently, according to the surgical note, it was intraaxial. But I think you could debate it. There's clearly dural thickening here. It looks like the parenchyma's collapsed around it. But there is also a little bit of hypointensity between the dura and the lesion itself, although I would still contend that perhaps this is actually extraaxial. So that's a tricky one. So it's not always so easy. Case 4 was an unusual tumor, an ATRT, rhabdoid territory, rhabdoid tumor, sorry. And it's mainly intraaxial, but it does have what looks like an extraaxial component to it. Case 5. So again, another very multicystic tumor, but notice how, again, the parenchyma looks like it's collapsed around it, and there's no parenchyma between the falx and the tumor itself. And I think that's quite helpful. If you can see cortex at the edge of the tumor border, the lateral border, sorry, then that's a helpful sign for an extraaxial mass. So this is a meningioma. This one's a very unusual one. And it does look like it's involving the cortex and the parenchyma here. But if you notice the pattern of it, especially if you scroll through the images, it sort of has a feel that it's surrounding the fissure. And this turned out to be an unusual meningioma, and in fact a low-grade one, so an angiomatous meningioma. So just examples showing that it's not always that straightforward to decide between intra and extraaxial. in terms of meningiomas, of course, if you call something extraaxial and then you call it a meningioma, you're highly likely to be right, more than 90% chance, because the majority of intracranial tumors and dural tumors are meningiomas. So we've seen classic appearance already. And a reminder that the meningioma, the cell of origin of the meningioma, is the arachnoid cap cell. So it actually comes from the arachnoid membrane rather than the cells within the dura mater itself. So the arachnoid cap cells that are part of the barrier between the arachnoid and the dura, or found in arachnoid villi. And a very typical histological appearance of meningioma, and the pathologist will often point out to us the whorls that form these cells, sort of spiral around various structures to form these whorls. Very typical. And this is from a book, but I thought quite interesting. The skull has been taken off the brain, and here is the meningioma. And look what a deep, this is a grade 1, sort of benign meningioma, and how sort of deep that indentation is, and how sort of well defined it is. I was quite surprised to see that. Okay, so meningiomas tend to affect females more than males. In terms of genetics, we know about propensity for meningiomas with NF2 and maybe also MEN1, but other than that, there aren't many sort of predisposing genes that are well characterized. The majority of them are asymptomatic and often incidental findings, but of course meningiomas, when symptomatic, are a very troubling disease. There's a huge number of types and subtypes, and that's resulted in various classifications and reclassifications of meningiomas. But effectively, is about where the classifications that is used at the moment and has been refined has been used since the 1930s. Location-wise, again, we're probably quite familiar with different types of meningiomas. We often see them at the skull base, but the most common ones are going to be the convexity meningiomas. But you can find them at the olfactory groove, the sphenoid wings, foramen magnum, in the posterior fossa, and then don't forget the cavernous sinus. And this is a nice illustration of either convexity meningioma, one that's along the falx, so falcine meningioma, and parasagittal, i.e. it's not actually originating from the falx itself. Excuse me. So the next polling question is, no images for this one, but the question is, what do you think are the two most important prognostic factors for the natural evolution, or not so natural evolution of meningiomas? So you have, you can choose multiple choices here, but which two do you think are most important? So is it the patient's age, how much a meningioma is resected at surgery, what the actual grade of the meningioma was, how big the meningioma is, or is it something that we need advanced imaging to work out? Okay, so if you think we've got enough answers, happy for it to be closed. Thank you. Good. So almost everybody agrees that histological grade is a very important factor, but quite interesting to see the spread across the others. And in fact, the other important prognostic factor is if a meningioma undergoes surgery, then the extent of resection, much more so than any of the demographics or the tumor size. So the grade and the extent of resection are two very important features to understand when looking at these. So why is grade important? So the majority of meningiomas are going to be benign, grade 1. And then a substantial minority are atypical meningiomas, a grade 2, so they have a high rate of recurrence. And then a very small minority are anaplastic or effectively malignant. And this is shown quite nicely in this data, which shows progression-free survival in the top survival graph. So a clear difference between the three types, and overall survival. And anaplastic meningiomas have a very pretty poor prognosis and a very high chance of recurring. They can be very difficult to treat for that reason. Okay, so here is an example of a grade 2, an atypical meningioma. So notice how there's maybe more heterogeneity, there's some areas that are cystic, high T2, but that in itself is not that helpful. We saw some cystic meningiomas earlier, but the border with the brain parenchyma is a bit more irregular and less well defined. There is also quite a lot of edema. However, that's not always a very useful characteristic, because secretory meningiomas, which are low-grade meningiomas, can also generate an unusually high volume of edema around them. However, most atypicals will have quite a lot of edema associated, and that may suggest in some cases brain invasion, or maybe due to brain invasion. And brain invasion is one of the features that define a high-grade or grade 2 meningioma. So this is an example of a slide of brain invasion. So this is brain tissue, and you can see these frank invasion of meningothelial cells into the brain tissue. Normally, you'd have a very clear separation between the two. This is an example of an anaplastic or grade 3 meningioma, quite an interesting case. So this is a patient who's already had surgery in the past. So on this T2, you can see this fairly homogeneous lump that's now extracranial, overlying the cranioplasty. So clearly a recurrent tumor. In fact, at that stage, there was an incidental lump found in the parotid gland. And when this was biopsied, it came back as meningioma. So this is a really rare sort of malignant or metastatic meningioma. And not too long after, maybe a year or so later, he's recurred in a formidable way, even though all this had been resected and this original tumor or first recurrence had been resected as well. So you can see how it can be a really horrible disease. So the management of meningioma mainly can be either surveillance, so watch wait with cat-like vigilance, or surgery, which is a treatment of choice where the aim is for a complete resection of the tumor. But sometimes, depending on the site of the meningioma, that may have to be a subtotal resection. And if that's the case, so if it's a subtotal resection, or it's a higher grade 2, grade 3 tumor that has a high risk of recurrence, or there has been no surgical option because of the location of the tumor, then the next option is radiotherapy, so either external beam or stereotactic. There's no role yet for chemotherapy or any other drugs so far. So we talked about one of the prognostic factors being the extent of resection, and that comes from this work with the Simpson grading. So Simpson was a surgeon, and he looked at the correlation between the rate of recurrence and the extent of surgery. And most surgeons will note the Simpson grade at the time of operation, so that when it comes back to MDT afterwards, he can make a reasonable decision as to how to manage next. So grade 1 is a complete resection, and grade 5 is effectively a biopsy, so almost no resection of the tumor and everything in between. And what this graph shows is the risk of recurrence. So as the grade increases, there's clearly an increased risk of recurrence. So the current NICE guidelines, which came out in 2018, are based on the extent of surgery, so the Simpson grade, and of course the location of the tumor and what options are available. So essentially, if you have a completely excised tumor and it was a benign tumor grade 1, then you might consider active surveillance, but no need for further treatment, whilst higher grades will be either more surgery or radiotherapy. Surveillance or radiotherapy. If they're incompletely excised, then the guidelines suggest, well, offering further surgery if it's possible, or radiotherapy or surveillance. And this is where it becomes a bit more difficult to know how exactly to manage, especially the lower grade tumors. If there has been no resection, so surgical, no options, then it's radiotherapy. And for recurrent disease, it's either try surgery again or radiotherapy. And here they also suggest a sort of scheme, especially for the active surveillance, as to how to do those. And I'll draw your attention to this one, which is the asymptomatic incidental meningioma. So your 10mm calcified meningioma in a patient who had a CT scan for their fall on rivaroxaban, which was normal. Other than that, what do you do with those? My personal inclination is to sort of play it down, but what our MDT does now is follow these guidelines, which is effectively scan in about a year to make sure that these meningiomas are not changing in size, and we have been caught out in the past. And then if it's stable, then you can either discharge or perhaps consider a much later scan in the future. On the other hand, there's a more intense schedule, of course, for the higher grade tumors, which are at high risk of recurrence, but also for the lower grade ones, where you might scan initially every year and then every couple of years after that. Remember also post-operatively that the first scan should be done around 3 months. There's not much point in doing an immediate or early post-op scan to try and work out whether there's residual tumor or not. Let's talk a little bit about radiotherapy. So we mentioned the reasons that that's considered, and the kind of locations where it's often where radiotherapy is often needed is because there are fewer surgical options, and that's cavernous sinus, optic nerves, and the ones that go through foramina. So here is an example of a very, very large meningioma. That's involving the cavernous sinuses, extending into the temporal fossa masticator space, through foramen ovale, and also towards in the clivus and towards the brain stem. And you'll find that the oncologists who are very good at outlining these tumors will sometimes ask for your help. So it's helpful to know which sequences are quite good to delineate these tumors, but also important, therefore, to understand the anatomy to help guide their treatments. So exactly how far does this tumor go? And I find certain sequences, so beyond the post-contrast T1, heavily fat suppressed sequences, whether it's a 3D flare or T2 weighted flare, or even diffusion weighted imaging, regardless of the actual diffusivity. I find these really useful in understanding the extent of the tumor. Whoops. So we'll just let this loop through a few times. But what you'll notice is, hopefully you can see this and it's not too fast for streaming, but what you'll notice is that on the T1, you can see the enhancing tumor, but it's quite hard to know where it is, for example, in the muscles below the skull base. But if you look at the DWI, it's actually quite well outlined. And correlating these two together, or a fat suppressed flare, are quite good ways of looking at the detail of these tumors. So that's my tip for you. Don't forget to look at the DWI. And here's an example where a patient was undergoing radiotherapy, and it's just an example where occasionally we'll use some other type of imaging. We don't do any spectroscopy routinely here, but We occasionally do methionine PET. And this was for a case of atypical recurrent meningioma, where they had 3 sites of meningioma, so at the craniocervical junction, planum, and in the ethmoid region extending into the orbit. And then post-surgery, which is this last image, we still have that ethmoid tumor, but there was also what looked like a possible new nodule near the optic nerve and the clinoid. And the question was, is that a actual meningioma, or is it just post-surgical effect? And so the methionine PET helped because it clearly shows a focus of increased uptake at exactly that spot. And so that helped the oncologists to plan their radiotherapy, which included that area which otherwise it might not have. Okay, so that's enough probably about management of meningiomas. We talked about the fact that there are many, many different types and subtypes of meningiomas, and some of those confer a specific grade on them. And although most meningiomas look alike, let's face it, sometimes they don't. And so the next question is, if you have a look at these images, there's nothing on Paxman for this, but the next poll question I'd like to ask you is, what type of meningioma do you think this is? You've got many choices, but here is a very heavily T2 intense mass. It's clearly extra-axial, and post-contrast actually not that avid, not that homogeneous. So any ideas? And of course, this is the game you'd play at the MDT just before the pathologist gets a chance. Okay, should we close this one? What did you all think? Ooh, very nice spread, but the majority went for microcystic. Very good. So absolutely. So this is the T2 weighted, the T2 intensity is possibly because of the formation of many, 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 many small cysts, some of which will then coalesce to become much larger cysts, macroscopic sort of cysts. But this is a grade 1 microcystic meningioma. And these big holes here in the pink are those cysts. Okay, the next one, there's no poll. I won't make you suffer through that. But this is a very nice case that came from Dr. Carlton Jones. And have a guess at this one. So have a think. We've got this very T2 hyperintense lesion again. So now we know that meningiomas could be like that rather than just iso-intense. But notice on post-contrast with fat suppression, actually a lot of it does suppress, but not the edge. Without fat suppression, this is also with contrast, but now you can see the fat. And this is on a flare T2, which also includes fat suppression. And notice again how it is suppressed. So it's clearly something that contains lipids. And if I told you that this was a meningioma, actually this is a very rare type. It's a subtype of some sort of metaplastic meningioma, so the cells have undergone metaplasia, but there are different names for it in the literature, from lipidized, i.e. including lipid, or xanthomatous, lipomatous meningioma, and there's clearly debate about what to call these rare tumors as well. So sometimes for the pathologist, the meningiomas can be quite difficult to classify. Okay, and what do you think of this one? So again, just have a think, no polling for this, but you've got a T2 hyperintense mass, some cystic areas, quite avidly enhancing. There's a lot of dural, massive dural tail effectively. And this is another type called the angiomatous. So you can see lots of blood vessels within the tumor. The reason I'm showing this to you is that one of the meningiomas that we saw at the beginning when we were looking at intra and extra-axial tumors was also angiomatous, which is this one. And this is another example of an angiomatous tumor. to my eye, there's not really a pattern on imaging that's that helpful. So I think the only type that you may recognize are microcystic, perhaps secretory because they produce a lot of edema, and also semomatous because they contain lots of semoma bodies, which are the mineralized whorls, or effectively lots of calcification. Okay, so that was a brief diversion to subtypes, which you probably never need to remember again. So what about tumors that are not meningiomas? Are there any features of a meningioma or of a dural tumor that we can use to try and work out, to try and predict this? So this is a recent series of about 350 patients just published last month, which looked at the atypical lesions in their series, so the ones that turned out not to be meningiomas, and tried to characterize any features. They actually had about a 7% prevalence of non-meningioma dural lesions. And they looked at a number of features, including hyperostosis, enhancement pattern, whether there's leptomeningeal involvement. But the ones that they found may be helpful are actually bone erosion, a marked change in T2, whether it's hyper or hypo intensity, the absence of a dural tail, so is suspicious, and dural displacement. To be fair, I think some of these are quite difficult, particularly the T2 intensity, because as we've seen examples of already, you can see that in meningiomas too. But I think the useful ones are probably bone erosion as opposed to hyperostosis, perhaps absence of dural tail, but I think that's iffy, but dural displacement, and we'll look at some examples soon. Okay, so if you go to Paxman for the next case, this is case 7, and Tom will put up the link in a sec. And maybe have a couple of minutes to look through this case. Thanks. So the link is in the chat. When I say a couple of minutes, I probably mean a few seconds, really. So what we should be looking at is case 7, meningeal tumors. Oh yeah, yes, if you could go ahead and start the poll for it as well, please, thanks. I've just put another link in the chat for case 7 and 8, just in case the first link took you to a different case. Okay, so if you'd like to answer the question, we'll give another 10 seconds. So what do you see any atypical features here? And what's your diagnosis? All right, let's close that poll. Tom, thanks. Great, very good. So you've seen abnormal flow voids, absence of a dural tail, maybe hard to say, isn't it? If you look on the sagittal, there's a bit of thickening on either side, but it's quite difficult for such a large lesion. And we had some thoughts of very high T2, very low T2. So thought it was somewhere in between. I didn't find that particularly helpful here. Maybe no atypical signs. What do you think the diagnosis was? of course, if we're talking about meningiomas, the first abnormal case that comes up is almost always hemangioparasitoma, isn't it? But you're absolutely right. So these flow voids, I think, are particularly helpful, although we have a couple of cases, a few cases of hemangioparasitoma where they just look like meningiomas. So these can be difficult. Hemangioparasitomas are now part of a spectrum of solitary fibrous tumors. So they're not a separate type of lesion. And they often don't have any calcification. You may get some bone erosion. And as some of you said, perhaps no dural tail. But the flow voids are quite helpful to identify these, or at least suggest these. The reason they're spectrum with solitary fibrous tumor is because they have some genetics in common, including positivity for STAT6 expression. And the cell of origin isn't entirely clear, thought to be parasites and around blood vessels, but it's debated. But the point with these tumors is that they're usually high-grade tumors, especially the hemangioparasitomas, and they're very, very vascular. So the surgeons like to know about it beforehand. And this is a kind of pattern you might see in histology, which is a pattern of no pattern and lots of branching blood vessels within the lesion. Okay, if you have a look at the next case, which is case 8 on Paxman. And Tom, if you could open the poll for this one as well, please. We'll just give you a minute to have a quick look through this. Probably pay attention to the axial T2 and the post-contrast T1. If you're looking on my screen, the CT shows a very hyperdense lesion. And if you don't mind, I'll give you just another 15 seconds to answer the questions, and then we'll have a look. Okay, let's close the poll. So in this one, maybe some bone erosion, but actually on the CT wasn't so clear. And if you look at the cortex here on the T2, it looks fairly intact. And yes, absolutely. So what you can see is dural displacement, and that is unusual. So here you can see the dark line hypointense on T2 of dura, and also on the post-contrast scan, sort of being lifted off the surface of the skull, of the calvarium, and that is the dural displacement sign. So probably quite specific for an atypical lesion, but not very sensitive. But when you do see that, that's quite useful to suggest that it's something else. In this case, and very good, this was lymphoma, so hyperdense on CT and fairly homogeneous and hyperenhancing on MR. So it's not very common. Sometimes these lesions are hypointense, as you might see within the parenchyma as well. And you may also see restricted diffusion, but then the problem with restricted diffusion, of course, is that you can see that in certain meningiomas, particularly atypical ones. This is just another example of lymphoma where you can see some dural thickening. It's probably gone through the bone, although not destroyed the bone, and then a large scalp mass. So here are some other atypical lesions. So if you look at this one, it's really centered on the bone, although extending into the orbit and the anterior cranial fossa. But what I liked about this case was how clearly you can see that the dura is pushed away. So it's not actually going through the dura. And this was a metastasis from a thyroid cancer. And these are other METs that often have atypical features, but they can, again, be quite difficult sometimes. So here's a large cerebellum metastasis, and there's a bit of dural thickening, and at surgery is found to have dural invasion. So it's probably parenchymal invading dura. These are METs from prostate cancer, and be extremely unusual to have a parenchymal MET, but dural ones are more common. In this case, there was no bone abnormality associated with it. And this is breast cancer where you've got dural thickening, more diffuse, but also some nodules. And similarly, again, breast cancer, this more subtle dural thickening. This just is an example of a really unusual tumor, but what it does show is the T2 hypointensity. Now, this is marked T2 hypointensity, progression of the tumor over a year. And on the CT before, you could just see some very subtle expansion of the bone of the sphenoid, but that then progressed. And this is the post-contrast scan. And this is a very rare tumor known as a desmoid tumor associated with FAP. I think the etiology is not the concern here, it's the fact that it's so low on T2, and you might see that with fibrous tumors. So as opposed to the focal disease, of course, you may also see more diffuse pachymeningeal disease, such as this case. And usually when you see this initially, there's a reasonably wide differential. And this particular case was GPA, granulomatosis with polyangiitis. There's enhancement and abnormal soft tissue at the orbital apices, but also this diffuse pachymeningeal thickening. But other types of cases to consider for this would be sarcoid, the usual suspect. In this case, sort of a nodular enhancement, but also pachymeningeal sort of nodule at the craniocervical junction, bit of enhancement in the optic nerves. This turned out to be sarcoid. Or diseases such as IgG4-related pachymeningeal disease. Again, fairly non-specific looking, diffuse, but quite smooth meningeal thickening. So there are a number of differentials for abnormal meninges, and this is a case of spontaneous intracranial hypotension. So the dura looks thick because of the CSF leak. Notice how I just wanted to show you this case because this again looks like fairly diffuse, smooth thickening. Of course, you've also got this nodule here, and this was breast cancer. And again, the DWI is quite helpful to show you that the overlying bone is extremely abnormal. So I don't know whether this is cancer coming from bone into the dura, or whether it's a reaction of the dura, which makes it sort of more smooth rather than nodular, irregular dural thickening. So that brings us on to the last section, which is just about leptomeningeal disease. So leptomeninges, of course, the pia extend down to the brain surface, so you'll see it in the sulci, and the main way to differentiate it from thick dural disease is that you'll see abnormal signal within the sulcus and at the very surface of a thin line at the surface of the brain. So here you can see this, you may pick it up on flare, so as abnormal lack of suppression of CSF because of whatever is in there, which could be blood or pus or tumor cells, and enhancement, such as in this case. This is a post-contrast flare, which also shows the enhancement quite nicely. Just some caveats, one of which is oxygenation. So if you have a patient who's intubated for their scan, for example, especially in the pediatric population, that oxygenation may lead to an artifactual T2 hyperintensity, flare hyperintensity. But it would tend to be, of course, much more symmetrical and uniform, but don't mistake that for a florid meningitis, for example. So if you have a look at the last set of cases, and Tom's kindly put the link, and we'll just take a few seconds. And what I'd like you to do is to have a quick look through the cases, maybe focus on flare and post-contrast T1, and try and decide whether the abnormality that you see is cancer or not. So the question is this cancer? And for each case, if you could answer yes or no. Oh, sorry. It's even simpler than that. which cases do you think are cancer? Is it case 9, 10, 11, or 12? Okay, so if you just take a few more seconds, you probably haven't had a chance to go through all the cases, but it's a good indication of your intuition here. Then once I've set my screens up, I think we'll have a look. Okay, Tom, let's close the poll, please. Thank you. So we've got yeses for all of them. Half of you agree on case 10 and case 11. So let's have a quick look. So case 9, not everybody agreed that it was cancer. And you can see on the flare this T2 hyperintensity in the sulci. What was quite interesting was post-contrast, there was a bit of enhancement in these areas here, for example. However, on a follow-up scan, these changes had resolved on the right. And actually what this turned out to be, which became much more obvious a few years later, was that this was florid amyloid angiopathy. And what we are seeing here was actually subarachnoid hemorrhage at the time of that scan. So that was not cancer, but a good mimic. And then this patient is probably a more obvious leptomeningeal disease. You can see that you've got a very large pituitary mass, but notice how there are also abnormal enhancing nodules, both that look pachymeningeal, but also leptomeningeal here in the cerebellum. And this is a much more classic appearance of leptomeningeal disease. So you're looking for enhancement and flare hyperintensity that are going into sulci. And I find areas like this, the cerebellum, are quite good, and the vermis are quite good indicators of that. This turned out to be a metastasis in the pituitary gland as well from her breast cancer. So similarly, you've got abnormal T2 hyperintensity here in the cerebellum, a mass in the calvarium, but also really florid leptomeningeal disease in this patient with metastatic cancer. And then finally, this was a tricky one. And this patient has what looks like some hyperintensity in her sulci on flare. It looks a bit swollen. And this is when leptomeningeal disease becomes difficult, because are you just seeing normal vasculature or is it leptomeningeal? And the areas that I find useful then are to look at smaller areas such as occipital lobe or maybe vermis of cerebellum again to try and work that out rather than up in the cerebral cortex. And this was meningeal disease, but this was a meningitis related to Behçet's disease rather than cancer. Okay, great. Thank you. Remember, of course, leptomeningeal disease can also involve the cranial nerves. So here you can see a breast cancer with involvement of the IAM on the left. As well as more nodular disease sort of around that area, around the skull base, going into Meckel's cave. And here is an example similarly of lymphoma affecting mainly cranial nerves, but also some leptomeninges with these diffuse, sort of thick enhancing tissue. Here is a very nice example going down the mandibular division through foramen ovale. And with leptomeningeal disease, it tends to be more infection and chemical meningitis rather than carcinomatosis when compared to pachymeningeal disease. This is a classic TB example where all the enhancement is down in the base of the brain, which then develops into tuberculomas. But this is also another example of TB. It's not always so obvious with small leptomeningeal nodules. Okay, so that was a pretty quick run through. We've looked at where question 1, which is, are tumors intra or extra-axial? If there's one thing you remember from this talk, I hope it's not the intracranial hokey cokey theme tune. But the thing to remember is if you think it is a meningioma, and if you call it a meningioma, you're going to be right 90% of the time, then look out for atypical features, which might give you an idea, or the surgeons an idea of the grade before they start. But of course, we looked at some differentials, such as the solitary fibrous tumor, hemangiopericytoma, METs, lymphoma, and differentials for diffuse pachymeningeal disease. Of the signs of atypia, probably displaced dura is probably quite most useful. For both pachymeningeal and leptomeningeal disease, the differential is fairly similar, except for the things that affect only the dura itself, such as the meningioma. But otherwise, infection and inflammatory diseases can occur in both types of disease. Great, so that's, I think I'll stop there. I think there were a few questions in the chat. If there's time, I'm happy to try and answer some of those for those who want to stay back. But that's the end of the lecture. Just wanted to thank all the colleagues who've helped provide cases and plenty of support so I could get this done. Thank you.
Thank you very much. That was a really comprehensive, and you got through a huge amount of cases. So thank you very much. There's a couple of questions which we'll just go through quickly, if that's okay.
Sure thing.
In the Q&A, someone has asked regarding follow-up of meningiomas, what's the role of giving contrast? Can you use non-contrast studies for follow-ups?
So I presume you're talking about meningiomas that have not been operated on.
Yeah,
so post-surgical, of course, you would give contrast, but I mean, we do it sometimes when there's some relative contraindication to contrast, and you're not particularly keen to do it. I think we'll accept that, but as a general rule, I think I would do it at post-contrast studies.
Great. So the next question is, do angiomatous meningiomas have any predilection for lying near to vessels, either arteries or veins?
I'm afraid I don't know. Not that I've noticed, but then I'm not sure I've looked at enough cases in a pattern. I mean, that the case that we saw around the left, Sylvian Fisher, was really striking. But I think a lot of the others, because meningiomas, of course, are generally more common around the convexities and near the falx, I think it's quite hard to say. So I don't know the answer to that. Yeah,
great. Any tips for the diagnosis of intraosseous meningiomas?
Oh, yeah. So I haven't really mentioned that. I mean, I suppose the quality of the appearance of the bone itself, it tends to be, with lots of spicules, but also very sclerotic areas. That's usually fairly obvious, for example, for sphenoid meningiomas, and we've had a few that have been referred to, to the MDT, thinking it was something else. But when you see the bone, it becomes quite clear. So I think that pattern of sclerosis and little spikes on the bone is pretty helpful. And of course, you may see meningeal thickening on the other side of that bone.
Okay. So we've got another question, which is how to differentiate meningioma recurrence from post-surgical changes.
Yeah, I mean, we generally just do conventional sequences and follow up over time. But I showed you a case of where we use methionine PET to look at that. Some places will try spectroscopy, although I don't know how well that works with post-surgical change, and of course, small volumes of tissue. Perfusion, diffusion, again, I don't have that much experience of in the context of meningiomas. Meningiomas are generally highly vascular. I'm not sure it's that helpful.
Yeah, and as you say, you normally delay the imaging a bit, don't you? So that you don't have the normal problems with blood products and things, because you hope
Yes.
that most of the by then. Yeah. Excellent. And then a couple of things about DWI. So do you ever use DWI to decide between typical or atypical meningiomas? And someone has said, is it particularly useful for hemangioparasitomas?
Yeah. So my flippant answer to that would be, I only use it if those are the pathologist's initials, i.e. you wait for the pathology ultimately in most cases, because it is so difficult. You do notice more restricted diffusion for atypical meningiomas, but I think I've always really noticed that in retrospect, and I'm not sure that prospectively I've actually made that call. Before seeing the histology, it tends to be more things like irregular borders and too much edema, with the caveat of the secretory meningiomas.
Okay, and final question. So you talked about methionine PET. Someone's asked if you have any experience with gallium dotatate to differentiate meningioma.
So I'm afraid I don't know. So we don't do it, as far as I know, we don't do it in our institution either.
Yeah. I think we've done it every now and then, but it's usually not that helpful for distinguishing it from the things that you actually want to distinguish it from. But we've not used it in kind of post-surgical setting, so
okay.
I'm not aware of that. Excellent. I think that's all of our questions. So I'd just like to say thank you to Dr. Das one more time for an excellent talk. So that will be available on the website as a recorded lecture, probably from Thursday. There's a feedback link in the chat now if you want to fill that in, and you should hopefully get your certificates by the end of the week. And next week, we're on to cellular and supracellular abnormalities with Dr. Jane Evanson. So come back and join us next week for that. But otherwise, have a fantastic afternoon and rest of the week, and we'll see you next week.
Great.
Bye.
Thanks very much, everyone.